So for neonatal care, how important is it doorway assessment to you, or the pediatric assessment triangle?
I'm not familiar with the term
Okay,
pediatric
so that
assessment
answers
triangle.
my
it's not.
question. That answers my question.
What is this pediatric assessment triangle?
It's a doorway assessment that has to do with three aspects of basically just looking visual of the patient, and just their appearance is part of it. And that to me is huge. Doorway appearance. Like, is the baby crying? Is it not crying?
So I will tell you, there's a lot I can tell you about a baby's condition just by looking.
Sure.
While I don't necessarily have a named tool, although with the exception of heart rate, I guess the APGAR score is an assessment.
The APGAR
It's just a
kind of
visual
lines
assessment.
up with the PAT.
But you can tell a lot about a baby's condition by, are they breathing? Are they crying? Are they pink? Are they flexed?
So same but different. It's, yeah.
All right, we've talked about the term baby
Mm-hmm.
who has everything going for it, may have some primary apnea, may have some things we have to work through.
You look terrified.
Let's talk about the sad part here. When is a patient not viable, and when is resuscitation futile?
So I will tell you that that's going to be a really hard thing to determine in the field. The real answer that we're using right now is that we are not resuscitating below 22 weeks. 22 weeks is, at the moment, considered the lower limit of viability. There's not really a weight that is considered to be viable or not viable.
And we certainly wouldn't know the weight in a field delivery.
It's generally based on maturity, and maturity is a function of mostly gestational age. But that's not going to be something, unless, if you come in and a baby is gelatinous and, 22 weekers are going to be gelatinous. This is probably not part you want in there. But if you come in and, well, I say there's no lower limit of weight. If a baby is not breathing and you have no equipment that is small enough to help breathe for that baby, that's a baby that we're not going to be able to help.
Yeah, that's fair.
And that happens to us in the delivery room too sometimes. And we'll be counseling families with babies who are around that age of peri-viability, and we'll tell them that sometimes the limiting factor here is that we don't have any equipment small enough.
Yeah.
But you're not in the field going to be able to tell a 22-weeker from a 24-weeker, or a 22-weeker from a 20-weeker or a 19-weeker.
Absolutely.
Or a 21-weeker.
Sure.
And at that point, the rules are sort of still the same. So you want to get that baby warm and keep that baby warm. In this case, you're not going to want to dry and stim. What you actually do is wrap them in plastic. And you can use, depending on what you have where you are, you can use saran wrap. You can put a baby into a Ziploc bag with the head sticking out. Right now we're using kind of fancy, sophisticated ponchos that have a little head covering, and it has Velcro down the center. But before we had the ponchos, we just had plastic bags, and we put the baby in the bag. And that's because they have so much surface area and their skin is so permeable that you're going to lose a lot of both their just general blood volume or fluid volume through their skin, and they can get cold very quickly. And so you want to keep that baby warm, and the way to keep that baby warm is going to be wrapping them in plastic. And so of all of the things we've talked about and the things that you can stock on trucks, if plastic wrap is not something you carry, that can be very useful. You want to put the hat on, and we're talking about the same hat. So the same one that might fit you.
Putting on a 19-week
or
a 20-weeker.
We'll put on a baby. So you get your baby, you put your baby in your baggie, you wrap your baby in plastic, and at that point it's exactly the same. So airway, breathing. When babies are at the edge of viability, these are babies that we often talk to families about not progressing to compressions if we can't get a heart rate above 100 with just airway and breathing. And that's because, as we talked about before, the issue is generally not the heart. The issue for periviability is always going to be maturity of your lungs.
Right.
And if your lungs are not mature enough to exchange gas, then no amount of compressions is going to get oxygen throughout your body.
Now, I think for some of the listeners hearing this, they're going to revert back to what we were just saying a minute ago, that as long as the placenta is doing what it's supposed to be doing, why cut and clamp? The baby's getting oxygenation through the placenta. Why can't we leave that baby attached still then and not cut it and transport? At what time does that circulation stop?
I mean, circulation stops when your placenta separates, and I don't think you have a good... You don't know when your placenta has separated. And even when you're at that point, you do want to establish airway and breathing. But even in these smallest of babies, we still do delayed cord clamping, and it can actually be most important for these smallest of babies to get that little bit of extra blood volume on their way out.
I guess let's so we don't have that confusion. What do we mean by delayed? We mean obviously not immediately, but 2 minutes, 5 minutes, 12 minutes.
We use 30 seconds for the smallest babies.
There we go.
That's what I'm looking for.
You don't, especially in bigger babies, you don't need to use that 30-second cutoff. And you're right, there are bigger babies who, I mean, if you want to go extreme with it, there are some families who choose to not cut the cords at all. In your vigorous, healthy term baby, if a family wants to stay connected, that's okay. In a baby who needs resuscitation, for the tiny ones, we use 30 seconds.
Okay.
That's
good to kind of put a...
If babies are doing well, for the tiny ones, they're just about always going to need resuscitation. Below 32 weeks, even if babies are crying, we put all of those babies on CPAP. And you'd be surprised, a 24-weeker will often come out crying.
Wow.
We can often resuscitate even your smallest of babies with just CPAP or just a few breaths and then CPAP.
That's so cool.
That is cool. do you
CPAP's
find...
cool.
So, right.
Non-invasive.
We should do a bit on that.
I know.
Yeah.
Are you
was
giving
our
a lot of
first episode.
surfactant?
Not in the field.
No, not the field. Are you?
Personally?
Well, NICU or...
Yes.
Yeah.
We do give a lot of surfactant. So, for people who aren't as familiar with it, surfactant is a detergent-like substance in your lungs. Your lungs make it. Your lungs make it throughout your life. There are two types of primary lung cells. The type 1 cells kind of surround those sacs that hold air, and the type 2 is the one that produces surfactant. So surfactant is this kind of slippery detergent-like material, and its job is to break the surface tension of water. And so if you think about a pool and doing a belly flop, think about how much it hurts with just trying to break the surface tension of that water. So then if you were to just drop a little bit of soap on there and think about that breaking apart more easily, that's what you're hoping for opening up the lung. And so it overall increases lung compliance, which makes it easier to ventilate and easier to oxygenate, and to do so with much lower pressures.
Right.
A baby starts to produce an adequate amount of surfactant to support its needs somewhere between 32 and 34 weeks gestational age. And so under that, it's very common to need surfactant. Over that, it's less common, but some babies still need surfactant.
I want to go back to ages and deliveries and more transportation.
Mm-hmm.
Okay.
So it's funny you say 22, because I know that OB's cutoff for taking a patient's 20 weeks. So we have taught, and it's in our protocol, at least locally, that 20 weeks is the cutoff. So if you're 19 weeks, we go to the local emergency department. They will see you and assess you. If the patient's 20 weeks, we say you need to go to a ER that's OB capable, that has OB services there. Because right now, I don't have OB services at my hospital. So it's interesting to me that OB will take them at 20 weeks, but you're saying viability is 22 weeks.
Mm-hmm.
So I think that making it easy for our listeners, at least within our med control, is that if it's 20 or if it's below 20, so 19 weeks and below, any ER is appropriate. 20 and above should go to a facility that has OB services, or if, let's say, they have a history of premature deliveries, or this is a highly complicated pregnancy, if they have the ability to go to a place that has NICU available services, that should be the destination. And picking those destinations is important. And maybe if it's going to add 5 more minutes to your trip, the local ER is 20 minutes away, but my NICU center is 25 minutes away. In that preemie of 20 to 38 weeks, that you should go to a NICU center.
With the caveat that if you are sure that you're going to be able to get to that place with a NICU center.
Also true.
So you're much more likely to have a better outcome delivered inborn than you are delivered outborn. And if you're going to have a preemie or a complicated delivery, you'd rather have it in an ill-equipped ED than in your truck.
I've got a lot more services in my ER than just the guy driving and the one in the back. Yeah.
You're the guy in the back. You get
There's
to
a problem. Like I was saying earlier off camera, I've delivered one in the field and it was in a taxi, and it was just, I'll never want to do it again.
All mine, which is only 3, I just was essentially there to bear witness. I mean, it was, let's take kid's coming out. And, it was, I was just there to clean up the mess. I wasn't really there to actually. I've done nothing to manipulate, help a child out ever. They've all just come out on the cot. But that was my time in East Cleveland, and it was just like, oh, the kid's out. Okay, cool. Here we go. Let's do the things I know.
And sometimes you can bring your NICU services to where you need them to be.
Also true.
So if somebody rolls into, we were talking about earlier, if somebody rolls into as a freestanding ED that isn't associated with an OB service or a delivery service or a pediatric service, if you need to, you can get on the phone and you can get both OB services, and in the particular case I was talking about, you got a NICU fellow too. And we were able to get together a team to safely deliver. These were 32-week twins, but to safely deliver by C-section 32-week twins in the OR of a freestanding ED with no delivery service.
Wow.
So
sounds terrible.
Right.
It was
it's a day.
Exciting.
Yeah.
But I mean, use the resources you have, and sometimes
Sure.
the resources aren't where you are, but they can be brought in.
Correct.
And the scheduling of NICUs is actually backwards from what we're
From
accustomed
trauma,
for what we're accustomed to with trauma, right? So we're always go to trauma 1 or trauma 2, and then this is actually
It's the opposite.
Yeah. Right,
so a level 1 NICU is, or level 1's not a NICU. A level 1 nursery is going to be your normal newborn service.
Got it.
Level 2 is
2 brings you what services?
So
or
2
capabilities.
2 you have a special care nursery.
Okay.
These are places that can take up to or no younger than 32 weeks.
Okay.
Or can keep no younger than 32 weeks. They can deliver CPAP. They can certainly do things like fluids and antibiotics and blood sugar management and that kind of stuff. Once by the textbooks, they can can keep ventilated patients up to 24 hours as long as they are improving. That's going to be very dependent on.
Seems subjective, but okay.
It'll be very dependent on your level 2 NICU.
Okay.
None of the level 2s in the area that we're in actually have that capability right now, as far as I know. This is all a point of controversy that you may want to take out too.
Well, we don't have to spend any time on it. Just the fact that it's backwards. The higher number is better in your world.
Right.
Rather than
So not better, but more equipped.
More equipped.
So
fair.
So a level 1's going to be your normal nursery. A level 2 can take as young as 32 weeks by the books, and they can do respiratory support up to CPAP, or non-invasive ventilation, and they can do your fluids and your antibiotic management and things like that. Okay. Once you're past that, you're looking at your level 3s, and these are the places that are going to have your surgical services and are going to be able to manage invasive ventilation.
Sure.
And level 4s are going to be the places where 3Bs and 4s are sort of different names for the same services. So there used to be 3A and 3B, and now I think we mostly talk about 3 and 4.
Okay.
But your level 4s are going to be the places where you're doing things like ECMO and preparing babies for cardiac surgery.
All of the cutting edge stuff. Got it. Okay.
Where are those centers throughout Northeastern Ohio?
Level 4s?
Well,
so
I guess Akron's probably going to be...
So Akron Children's is level 4.
Okay.
They have a network of delivery hospitals that have level 3s. So Akron takes deliveries, I know, from SUMA, from Akron General. Yeah, SUMA, Akron General, and those are their 2 main ones that go to Akron Children's. And those are both technically level 3s. Everything at Akron Children's is an outborn unit, and so they don't actually have a delivery service there.
Correct.
They get all of their babies from their delivery services.
Brought in, yeah.
So their delivery services have the level 3s. The level 4 is at their children's hospital. I come from UH. Rainbow is our level 4, so downtown. We've just opened 2 level 2s. So we have Southwest on the west side, and we have Ahuja on the east side. And pretty soon, Tri-Point is also going to be opening as a level 2.
Right.
And then we have a fairly extensive network of level 1s, or normal newborn nurseries.
Sure.
The clinic has its surgical services and its ECMO services downtown at its main location.
Main campus, right.
And then it has an east side and a west side delivering hospital, and those also operate as level 3s. So they have Fairview on the west side and Hillcrest on the east side.
Yeah.
Metro just moved its level 4, so it had the level 4, and this, I think they're pretty proud of this, but they moved from their older big bay style hospital to now a level 4, still serving the same area, but they have single bed units the same way that we do at Rainbow. Which is nice for the families there.
Yeah.
So yeah, those are going to be your main level 4s in the Northeast
In this
Ohio area.
area.
Rainbow, Cleveland Clinic main campus, and Metro. Akron is south of us, but their main level 4 is going to be Akron Children's with its 2 level 3s. And then when you're moving to other areas, Nationwide has a level 4 with
Columbus.
Nationwide and Columbus has a level 4 with a large network of level 2s and 3s. I know Cincinnati has its main level 4, and I know it has a big network of level 2s. I'm not actually sure about level 3s. But every place you go is going to have slightly different strategies for how they serve their community and how they serve their catchment area. And they're really doing what they think is going to be best to serve their patient population, depending where they are. So places have found that it is helpful to the community to have delivering services close to home. And as we said before, the majority of deliveries go well. The majority of deliveries are normal pregnancies with normal newborns that never need anything more than normal newborn care. And so for those families, having your newborn care close to home is really important. For more specialized care, just because of the nature of it and the needs for equipment and the needs for people and the needs for, 24/7 very acute care, it has to be more centralized.
Yeah, of course. So just kind of getting back to, we touched on this a little bit. We've clearly focused on the airway, the breathing, ventilation, oxygenation of the kid. Let's talk about some monitoring tools and what is and isn't different. We certainly talked about pulse oximetry a little bit. So let's get back to that because there's some nuanced stuff with pulse oximetry in the newborn. And then also let's talk about capnography. You said you just did a piece on capnography, and without getting into the nitty gritty of capno, I guess let's just start with that. Does anything change from what I'm used to if I'm putting capnography? So if I put an advanced airway in this baby, are my waveforms any different? Are my values any different? Am I looking for the same things, or are there nuanced things I need to know about with capnography?
The biggest thing to note with newborns and capnography, especially in the field when you're moving, or not in the field, in the truck when you're moving, is going to be, your number is not going to be as reliable as just having a waveform. So what you're using for capnography isn't really going to be an assessment of whether or not you are achieving ventilation to the CO2 that you are targeting. What you're really trying to see with your capnography is just, my airway is in good position. If I don't have a waveform, my airway is not in good position. Okay. And if I do have a waveform, my airway is in good position. I've heard a misconception that if you have an esophageal intubation, you'll still get a waveform. You won't.
Agreed.
You'll
see a slope.
Yeah, exactly. So especially
I hope that's not a misconception.
I don't.
that shouldn't be that shouldn't be a thing.
When you have been delivering bag max ventilation, sometimes you have actually bagged CO2 down into the stomach. And so in an esophageal intubation, you might see CO2 initially.
Value, right.
Yeah, you might see it initially,
right.
But no waveform, and it'll go away.
Right. Yeah.
And
so
that's scans.
And not come back.
But
as long as you have a waveform, you have a tube that is doing its job. Beyond that, because of the small tidal volumes of babies and limitations of the equipment, it's hard to get a reliable reading necessarily.
Value,
so what you're really looking for is a waveform.
Just waveform. No, that's great. That's great.
Good to know,
that's great information. Because
when you're talking about this is your tidal.
That's
volume.
your tidal volume.
That's probably the sampling.
That's the sample size of a side stream. Yeah.
Yeah. So.
Yeah, absolutely. Yeah, that's a great point. Because we spend, at least in this area, I don't want to speak to the rest of the viewing area, but certainly in this area, I think we focus a fair amount on the value itself and its impact on what that means to metabolism, perfusion, ventilation.
Yep. This is another point where babies are a very different group than older kids and adults, and especially preterm babies. Babies are remarkably resilient with derangements in their blood gas. And so babies can be remarkably resilient when they're retaining CO2. And while you will look at an adult with a CO2 of 55 and
be like, oh no, right.
Be very concerned, I will have a respiratory therapist hand me a blood gas with a CO2 of 55 and say, great, we're in target.
Meh.
Yeah,
Meh.
Exactly. Meh. And the reason is we work in a world of permissive hypercapnia, and for a couple of reasons. So one of the things that we're really trying to avoid with mechanical ventilation is going to be trauma, so trauma to the lungs, so barotrauma and volutrauma and even analectotrauma. And so the less pressure we can give, the less trauma that we are causing to those lungs. But also, having rapidly decreasing CO2 is not going to be good for perfusion, and especially brain perfusion either. And so babies are remarkably resilient with CO2s that are a little bit higher. And in some of these older babies, not ones that you're going to see straight after delivery, but in some of our more chronic babies, because they've seen higher CO2s for so long, and you probably don't even want to know what some of these higher CO2s babies have seen for months are. But
like triple digits?
Sometimes.
Really? Wow, that's nuts.
I've had babies who have triple digit CO2s for at least a week at a time.
Ooh.
Wow.
It's not a sign of health.
Understood, but still, it's still, wow.
But sometimes when you have babies who are riding CO2s that are higher in the 60, 70 range for a long time, you get their CO2s into the 30s or 40s, and their brain doesn't tell them to breathe anymore.
Okay. No, I mean, that scans. I mean, even for the adult population, right? But
so I'll tell you that 55 doesn't really bother me. I see 55 all the time. Over 100, I get concerned. For my education, are they compensated?
Yes.
Okay.
This is, stating the definition, which is going to sound silly, but the more chronic ones are going to be compensated.
Sure.
And so when you have a newborn with a CO2 over 100, that is a very sick infant. When you have a more chronic, so once
they've been there for a month and their CO2 is 80, but their pH is normal.
It's usually longer than a month, but when you have especially these babies who started off in that peri-viable range, who have very immature lungs, they go on to develop significant lung disease just from the amount of ventilation that is required in order to help them exchange gas. And as these babies get older, again, not a sign of health, but you'll see blood gases that are like...
They're just hypercarbic.
735, 108 with a bicarb of 55.
Oh.
So there are chronic COPDers that have been living there. I mean, I have a chronic COPDers at 70s, 80s.
Sure.
They're normal.
They
right?
live
Because
there,
they got
right.
a normal pH.
They live there, right.
Their bicarb's 40, 50s. So if I saw that in a kiddo...
Sure, yeah, we would.
If it's compensated, I'd feel better, but I'm still like, I shouldn't see that in a kid. But you're telling me there's kids like that, so.
There are. They are chronically ventilated.
Not thriving, but living.
They are chronically ventilated. These are babies who often go on to go home with trachs and vents.
Trachs and vents, yeah.
Well, it also tells me that I get a lot of Hattie's kids. So I haven't seen one blood gas that bad yet from Hattie's, but I will now.
Now you're on the lookout.
Now I'm on the list,
Now you're on the lookout.
I mean, I would hope that's an inpatient blood gas.
Yeah, I think that if they're these long-term facilities, though, these kiddos, they're obviously chronically sick. And I think that they do a good job of trying to keep them in that facility. And they're a little slower to push them out into the hospital system because I think they try to manage them maybe a day longer than what they should until they're really, truly sick. And
That's
they're
a thing.
yes, they now need to
Absolutely
go back
a thing.
into the acute hospital system and out of the long-term care. So that's been my experience with the long-term kiddos.
Yeah.
All right. Pulse oximetry. We talked about capnography and somehow spiraled that into
bad blood gases.
into some gases. Pulse ox. There was a couple things we talked about off air that I said we definitely need to, and that was the pre-postductal thing and normal sats for a newborn.
For a brand newborn.
So
the
what are the high points there?
High points. So a baby's going to come out with a SAT of about 65, which is about what the intrauterine environment is. That's why your baby's going to be blue. You have 10 minutes to get to a SAT of 90. I guess this is a little bit of a tangent, but another important change in NRP over the last decade or so has been there was a time when all babies were resuscitated with 100% oxygen. And then we moved on to resuscitating preemies, I think, with 100% oxygen, but doing less in term infants. And we have found over the years that more oxygen is not better. And in fact, the less you can use, the better. And especially in preemies, hyperoxia can sometimes be just as bad as hypoxia. And so NRP is pretty specific for term newborns. So we always start resuscitation of the term newborn at 21% and go from there.
Okay.
Certainly if you were starting compressions, you should have escalated from there to 100%.
Okay.
But
I was gonna ask at what point do we start cranking that up? But that's a great.
So you start cranking that up, and I brought you those little cards, but it actually, and you can see it on there. But if you're looking at NRP, it actually tells you what your SAT should be at what point in time.
Correct.
And if your SAT's not where it should be at that point in time, then you start cranking it up.
Our protocol has the same
same
table.
Then you start cranking it up. And you're not cranking from 0 to 100, but maybe you're cranking from, you're never 0, but you're not cranking from 21 to 100, but you're maybe cranking from 21 to 30 or 21 to 40 and seeing where you get. And so, there's your nice little table.
I think that's a good point to make because, we might be doing everything right, but we're treating the patient, not our machines, and we need to sit back and realize that there is a difference here, that we are switching states of oxygenation and that it's going to take a while to get them up to where our normal is.
Yeah. So if your baby is 3 minutes old and their SAT is 72, that's actually fine. There's no need to escalate from there. And so that's
going to be a high stress, low frequency thing for us though. So for somebody who's used to all the time treating patients and making their SATs at least 96 and above, it's hard for us to see somebody in the 60s, 70s and not act. But we need to calm down, relax, know our clientele, and take that breath and pull out Certidose.
Well,
We haven't gotten to drugs yet.
no, I would say if they're breathing and they're breathing vigorously and fast, 40 plus times a minute, I think they're good.
And they're pinking up.
And they're
Yeah,
picking up.
yeah.
Yep.
This is great.
Yeah.
I mean, for a term newborn, if they are breathing and pinking up, these are babies who may never see a pulse ox at all. And as we said, most newborns are healthy, and most newborns never see a pulse ox at all. But for a baby who does require resuscitation, where you want to monitor the pulse ox is also going to be important.
Yes.
So in adults, when you think of the ductus arteriosus, you only think of it in terms of the patent ductus arteriosus, and you think of it as being pathologic. All babies are going to be born with a patent ductus arteriosus. It's part of fetal circulation.
Required.
Yep. So the other part of fetal circulation is that blood is shunted away from those collapsed lungs that are not exchanging gas in utero. And so the lungs are collapsed down. The blood vessels are going to be small too. And babies are born in a state of high pulmonary vascular resistance. And that is to shunt blood away from the lungs when they're not using them. So the lungs get just enough blood to grow during fetal circulation. But otherwise, the blood is shunted back into systemic circulation. So babies are going to be born with high pulmonary vascular resistance. And as they start to breathe, those lungs are going to open up and the pulmonary vascular resistance is going to drop. So when you have high pulmonary vascular resistance, you're going to have less oxygen exchange or less oxygen delivery, which means, and as early on, so initially, the pulmonary vascular resistance is going to be higher than your systemic vascular resistance. And that's what it's supposed to be, right? So you shunt your blood across that ductus into systemic circulation. As your pulmonary vascular resistance drops and becomes lower than your systemic vascular resistance, first it'll be bidirectional, and then it'll be all left to right. So when you have blood shunting across your ductus arteriosus, everything before that, so everything that is coming from your lungs, is going to be oxygenated, right? So blood that is returning from your lungs and going out the left side of your heart into systemic circulation is going to be fully oxygenated. Blood that has gone to your lungs but the pulmonary vascular resistance is just too high and can't get in is going to shunt back right to left across that ductus, and is going to mix with that oxygenated blood and cause overall less oxygenated blood. So a better measure, or a necessary measure of if you are exchanging oxygen, is going to be, what is your preductal sat? What is the saturation of the blood that is being delivered to my lungs and then coming back
across.
Yeah, going back
Through.
from the lungs back into systemic circulation the way it's supposed to. So from the lungs into the pulmonary veins back to the left atrium. Not making it to the lungs, across the ductus arteriosus, back into the aorta. Does that make sense?
It does. For anybody that's seen an anatomy book, but
I was going to say, this is something that
It takes me back to the first year of med school.
This is something that often requires pictures.
Yes.
No. Explain it. We'll in post. We'll throw some pictures in there.
Yep.
Okay. So, the way postnatal circulation works is, if you start at the left ventricle, you have blood that is pumped from the systemic side of your heart, so from your left ventricle out through aorta to your body. It goes to the capillary beds, comes back through your veins, through the vena cava into your right atrium, goes from the right atrium to the right ventricle into the pulmonary arteries, goes to the branch pulmonary arteries to the lungs to get oxygenated, and from the lungs is going to go into the pulmonary veins back to your left atrium. So it's all a nice series. In fetal circulation, you have high pulmonary vascular resistance, and that is because you're not using those lungs to exchange gas. You're just getting them enough blood to grow. So blood, as it's supposed to during fetal circulation, is going to go through your pulmonary arteries, but the resistance is going to be higher. And so some of that blood is going to go to your lungs. A little bit of that blood is going to go to your lungs. but the majority is going to cross the ductus arteriosus from the pulmonary artery back into the stomach circulation.
Right to left.
So from the pulmonary artery into the aorta. All babies are born with this ductus arteriosus open. It's supposed to close. You're taught in med school that you take your first breath, everything slams shut. That's not actually really how it works.
That doesn't scan.
But it usually closes in the first several hours to few days of life.
Yeah.
But when a baby is first born, that opening is still there. And the pulmonary vascular resistance at the moment of birth is still going to be high.
Pretty high.
It takes a little bit of time for it to drop. You want it to drop quickly because that's how you start to oxygenate blood. So now your lungs are the organ of oxygenation. And so you need them to be able to get blood into their lungs to oxygenate. But it takes a little bit of time for that pulmonary vascular resistance to drop. And so when a baby first comes out, they will still have some of that blood going through the pulmonary artery, crossing that ductus arteriosus, and going back into systemic circulation. But now your lungs are actually oxygenating, right?
Right.
So during fetal circulation, the oxygen saturation of that whole system is going to be about the same because the lungs aren't oxygenating.
Yeah.
So blood comes into the baby through, in this case, in every case, blood goes into the baby through the umbilical vein, and it is oxygenated there. At that point, it is oxygenated coming into the umbilical vein from the placenta. At that point, everything in the baby is using oxygen. It's not in any way absorbing, it's not bringing it in from anywhere else. So everything in the baby is using oxygen, and it brings deoxygenated blood back out through the umbilical arteries. So you're going to have oxygenated blood at that point going in through your pulmonary vein and deoxygen coming out through your pulmonary artery, through your umbilical arteries. But in that case, the lungs are not going to be your organ of oxygenation. Once they're open and once the baby is not attached to their placenta anymore, all of the oxygenation is coming from the lungs.
Right.
So if you then have deoxygenated blood going from the right side of your heart out the pulmonary arteries to go to your lungs, but the pulmonary vascular resistance is higher, then some of that blood's going to go through just like it was before, but some of it's not. And so you're going to have deoxygenated blood being shunted from where it should be going in the lungs across that ductus arteriosus back into systemic circulation. So then if you think about the aorta, the ductus arteriosus comes off what is before the ductus arteriosus. So in that little part of the ascending aorta that is before the ductus arteriosus, you have the blood supply to your right arm and the blood supply to your head. Everything else is going to be supplied after the ductus arteriosus. Yep. And so if you think about it.
So it's vessels, vessels.
Right.
in order, essentially,
yes,
right.
And we could talk more about them if you want to.
No, but to make the point where to sample it is
exactly.
They need to understand this part of it.
Right. So the blood vessels that supply your right arm are going to be coming off the ascending aorta before your ductus arteriosus. Yep. So that is going to be all blood that was going from your left heart that has all come directly from your pulmonary veins back into the left-sided circulation. Everything after that, so except for your head and your right arm, everything after that is going to see the influence of whatever shunted right to left across your ductus arteriosus. Right. And so if you have increased pulmonary vascular resistance, that SAT will be lower if your cardiac anatomy is normal.
We'll say the cardiac anatomy is normal.
That SAT will be lower. Eventually, they will match.
The pre and post.
Eventually, your pre and post should match. Yep. But in the very beginning,
the right side, just so we can say that simply, the left side and the right side will eventually match.
Catch up.
Yeah.
Is that a sign that the ductus is closed? Do you guys use that at all?
So it can be a sign that the ductus is closed. If you don't have a ductus arteriosus, then you don't have a pre and post ductal SAT.
Fair.
So people will still try and measure them.
Okay.
But if you don't have a ductus arteriosus, then your pre and post ductal are going to be equal because there's nothing to shunt across. But it can, if they are equal, it can also just be a sign that your pulmonary vascular resistance has dropped and you have equal PQPS.
Okay.
But if they were initially different.
If they are initially different, so if you are
and now working towards each other, that means we're closing.
No, that
Not
means
necessarily.
So if they are initially different and working toward each other, the most likely explanation and actively working, so your postductal is rising. That is more likely a sign that your pulmonary vascular resistance is dropping.
Okay. Yeah.
They're exchanging gas. What do you do for a ductus that has decided to not play the game and it's not closing?
For the ductus? In the very beginning, we wait. This is sort of a hot topic in neonatology, and especially in preterm neonatology.
You got to change everything I learned in med school now? Because I know the answer is. I had this question.
I think I know the answer to this too, which is weird. Go ahead.
So I'll tell you that we almost never do open ligations anymore, if that's what you're thinking.
Oh, God,
no. But the short answer is we do close them. We usually give them some time to close on their own. If they do not close on their own in the hospital setting, if we think we are having issues with the ductus arteriosus, first of all, you'll have signs from the baby. So you will have a murmur. It's not generally that classic machine-like murmur that we learned about in med school, although it might be in older kids and adults. But in babies, it sounds more like just a systolic murmur.
Okay.
You'll have your murmur. You'll have signs of turbulent flow. And so you'll have widened pulse pressures. You can not really see most of the time, but you can feel pulses in the baby's palms. And those are all signs that you have an open ductus arteriosus or a patent ductus arteriosus. This is never going to be something you want to close during that initial high pulmonary vascular resistance time. Because if you were to close it when your pulmonary vascular resistance is high, during that initial kind of dropping of your pulmonary vascular resistance, what the body is using that ductus for is to shunt across. And if there's nowhere to shunt across, then you can have an acute pulmonary hypertensive crisis if you close off that opening. But later, after your pulmonary vascular resistance has dropped, you'll start to see the opposite through that ductus arteriosus. So rather than right to left shunting, which lets you know that your pulmonary pressures are high, you'll start to see left to right shunting. Right. And that is just the high systemic pressure shunting back toward the lungs, which can cause over time fluid overload, pulmonary edema. Initially, when you have pulmonary overcirculation, you'll see higher sats. But as you start to develop things like pulmonary edema, or even if you go way down the line, you can actually develop pulmonary hypertension from pulmonary overcirculation.
Okay.
But in that middle point, that's the point at which we start to think about closing the ductus. When we are having difficulties with oxygenation because of pulmonary edema, when we have signs that we have turbulent flow with your widened pulse pressures and your pulmar pulses, and I'm doing a really bad job explaining this.
No, that's okay. Are you doing it chemically or mechanically?
So that's what I was getting at. So when we first start to see it, so when we think a PDA might be starting to give us an issue, so we're starting to see signs of pulmonary edema, we will start doing it medically. We'll first try to do it medically. So there are multiple ways we can do this. The traditional one that you probably learned in med school is Indocin. So you can use NSAID. So Indocin has sort of fallen out of favor. If you're going to use an NSAID, the more likely one is going to be ibuprofen. More recently, there's some data that Tylenol or acetaminophen can also work to close your ductus. And so oftentimes, because in the case of trying to close a ductus, babies will often have things like acute kidney injury, and that's from the turbulent flow stealing blood away from the renal arteries. So if you have acute kidney injury, you can make acute kidney injury worse using an NSAID. And so Tylenol has kind of come into favor because it has less side effects and less effects in the ways that our babies are already sick. And so we'll usually start with usually now Tylenol, but either Tylenol or ibuprofen. And we'll give sometimes more than one course of Tylenol or ibuprofen. And if our ductus is still open and still causing us issues, at that point we move on to mechanical closure. And in recent years, we're not doing open PDA ligations anymore. What we're mostly doing is catheter device closures.
Wired, yeah.
Very cool.
And
when I say we, these are done by interventional
cardiac surgery,
cardiologists,
cardiac
not
surgery,
us.
right.